Good morning, class. So I'll give you a case scenario for today. Today, a patient has come to OPD with from an OBG reference, stating that they need a fundus examination. But as you know, in an OBG or a neurosurgery, they require pupils to be undilated because DCS score is really important. So what is the mechanism? What is the instrument or what is the machine will you use to check for the fundus? So now comes the important thing of the direct ophthalmoscope. It was first invented by Dr. Helmont in the year 1851. Coming to the different parts of the direct ophthalmoscope, in the patient side we have the viewing window, the aperture dial, the filter switch, diopter dial, and also the on and off switch. In the practitioner side we have the grow rest, the viewing window, the aperture dial, and also the diopter power display. Next, coming to the different apertures in the direct ophthalmoscope, you have the small aperture, which is used for viewing the fundus in the undilated pupil. Next is the large aperture, which helps in viewing the fundus in the dilated pupil and also for viewing the red reflex. Next, we talk about the fixation aperture, which is a good aperture for an eccentric pupil and helps in viewing the fundus without masking the macula. The last will be the slit aperture, which helps in viewing the elevations in the fundus, especially the edematous disc. Next, coming to the different filters. Next, coming to the different filters in the direct ophthalmoscope. The first is the polarizing filter, which helps in viewing which helps in reducing the reflections in the fundus. Next is the green filter, which helps in viewing the hemorrhages and also the RNFL defects in glaucoma. Now coming to the cobalt blue filter, which helps in viewing the corneal aberrations as well as the punctate keratitis. Coming to the optics of the direct ophthalmoscope, from the lamp filament, we have the rays of light that condenses on the lens 1. The rays of light condenses on the lens 1 and through a small aperture in the ophthalmoscope as mentioned previously. Then on the lens 2, which further condenses the rays of light onto the reflecting mirror at angle of 45 degrees. From there the rays of light pass out in subject's retina and they refract back to the hole in the ophthalmoscope onto the compensating lenses and forms the image on the observer's retina. How to perform the direct ophthalmoscope? We in a semi-dark room, we observe first for the red reflex and then move as close to the patient's eye as possible till we view the fundus. Next, coming to the optics in the image formed in the emetropic eye will always be an erect image. In hypermetropic patient it will be smaller, whereas in myopic patients it will be larger. In a hypermetropic patient, the diverging rays of light form the image behind the retina, whereas when you use the compensating convex lenses, they form the image directly on the retina. Similarly, in a myopic eye, when we use the compensating concave lenses, we form the image directly on the retina. That's why compensating lenses are important. In astigmatic patients, the full view of the fundus cannot be secured because the correcting lenses used are mostly spherical. Therefore, one meridian at a time can only be visualized. Coming to the field of illumination, it is directly proportional to the size of the pupil and inverse proportional distance. At a distance of 15 cm in an undilated pupil, nothing of the fundus can be visualized, but at a 2 cm distance in an undilated pupil, a magnified view of the disc can be easily visualized. And similarly, in a 2 cm in dilated pupil, the disc as well as the periphery of the fundus can also be visualized. Coming to the advantages, direct ophthalmoscope is highly portable. Highly magnified view of the disc can be seen.
Time is up. Okay. Go ahead. Go ahead. Okay.
Yeah, very good description. Can you tell us what would be the optics of direct? What would be the difference from the optics of indirect ophthalmoscope? And then what would be the advantages of direct over indirect, which are very few now?
In direct ophthalmoscope, we can view the periphery of the fundus easily, but it will be cumbersome because pupils have to be completely dilated. Otherwise, it is of pupils have to be completely dilated to view the periphery of the fundus, and as well as it is not portable. And a DO is easily portable. As you can see, I am carrying it right here in my pocket, so it's highly portable. And in cases like, as I mentioned in the scenario in the beginning, that in a case of a neuro surgery patient or an obs gynae patient comes we have to view the fundus without dilating the pupil, because pupil reactions and their assessment is equally important for the GCS score. As a result, DO is more good in such scenarios.
So I think the optics of direct makes the interpretation easier, because we don't have to invert the image.
It is a
invert the image. The image is not a
inverted or real image. It's an erect and
so that
virtual
is the
image.
advantage. But the disadvantages are too many.
It is very close contact patient.
Yeah,
Very
very
and it
close
is not it is uniocular, not binocular. So the
Yes.
assessment
limited field of view.
Yeah.
So those are the disadvantages, and that is why indirect has become the instrument of choice. But now indirect is also portable. So portability is no longer a problem, because they are cordless now, light and cordless. So portability is not an issue. But the optics have only one advantage, which is a magnified image, and second is it's not inverted. So that's the difference. But in most situations, indirect would score. Anything else you would like to say? Advantages of one over the other, direct or indirect.
Advantages of direct, as I mentioned, ma'am, it's
So that's what is mentioned, no? Anything else?
a magnified view of the disc and the fundus will be visible. So minute changes in the vessels like the
Also, it helps us to assess the opacity caused by lens and or the cornea, so that we are able to assess the practical amount of visual disability caused by the media opacity with a direct ophthalmoscope, which we cannot do with an indirect ophthalmoscope. So you can assess the cataract better with a direct